Hi everyone, good afternoon and good morning if you're somewhere else, like not in England, or good evening if you're in Asia. So well, we're just waiting for people to come in, just to let you know a few housekeeping things before we start. So I'm Maria Hawkins. I'm professor of radiation oncology, and I work at UCL and University College London Hospital, and I'm a clinician scientist with an interest in GI. This meeting is recorded, and the idea of these seminars are intended to initiate connectivity, give people insights in radiation development in both clinical and non-clinical areas, and also offer perhaps doors and opportunity to collaborate. If you've got any questions or comments, please put them in the meeting chat or raise your hand. Our speaker, Jennifer, will speak for 45 minutes and we'll have 15 minutes for questions. So I think that's sort of with the housekeeping rules. But what more important thing is that I would like to introduce our guest, which is she's from Boston, a radiation oncologist who trained in Harvard, and since 2010 she's on the faculty in Massachusetts General Hospital, and her interests lie very close to my heart in GI radiation oncology. She has established herself, so Jennifer has established herself as a clinical expert with a national and international reputation in GI radiation oncology. She's an extremely prolific writer, and she's got more than 90 publications in journals with high impact factors such as Clinical Cancer Research and Nature Medicine. She's been awarded the Anne Klibanski Visiting Scholar Award in 2021, and we are grateful we can host her here to our seminars today. And it's unfortunate if this visit is virtual. And today she will discuss the potential roles of protons in GI radiation. And I think that discussion is timely because we've opened a proton center in just a couple of months ago here at UCLA. So I'm going to stop sharing and let Jen speak. Welcome. Sorry, I forgot to be polite also.
Well, thank you so much, Maria, for that introduction. Hopefully you guys let me know if you're not seeing the right thing.
So okay, you're seeing your screen. Thank you.
Perfect. So, for the next 45 minutes, I'm going to go through our experience of proton radiotherapy and really focusing on GI cancers, which is what I do. And the talk is better outcomes or just more costly. And I think it's really timely. MGH was one of the leaders of doing proton research, and many other facilities have developed it since. And the NCI appropriately is putting increased pressure on all of us to sort of demonstrate clinical benefit beyond just improved dosimetric image, plans. But does it actually correlate with clinical outcome? And so I'm going to do sort of a lay of the land for you guys and then talk about some of the challenges that we've experienced. Oops, sorry. These are my conflicts of interest. So as many of you know, proton radiotherapy is a particle with charge and mass. And so there is a defined range in tissue, which is proportional to the energy. And this red beam on the right is a native proton beam where you can have a distinct sharp Bragg peak and then no dose delivered beyond that point. To treat a tumor, you would have a spread out Bragg peak towards the surface. And this in contrast to the pink, dose depth curve of a photon beam where you have both entrance dose and exit dose. And so you can have unwanted dose to normal tissues. And this is just another depiction. This is the red image is the tumor, and you can see with the spread out bag peak. Ideally, right after the distal edge of the tumor, you can have a sharp dose fall off versus a photon beam where you have, once again, entrance and exit. So clinical, potentials for clinical benefit for proton radiotherapy, and it really hinges on narrowing that therapeutic index. Proof of principle, protons may allow for one, a decrease in acute and late toxicity. And by doing that, it can potentially impact long-term quality of life and even potentially improve overall survival. By allowing, once again, improvement in toxicity profiles, you can also imagine a situation where radiation may allow for dose escalation and thereby improving local control. And then something more exploratory, but is very much on the horizon these days. There's increasing data to suggest that perhaps with proton radiotherapy, you can decrease lymphopenia, and that may improve immune surveillance, and that may in and of itself improve overall survival. So all really different interesting facets of potential benefits. So this is sort of the lay of the land right now. There are two ongoing phase 3 clinical trials in GI. One is for liver cancer, primary liver cancer, one is for esophageal cancer. And there are ongoing phase 2-3 studies with anal cancer. So that's where I'm going to focus my talk today, because that's where most of the evidence is. And then out of the scope of the discussions today, there's been literature published about pancreatic cancer, rectal cancer, and certainly reirradiation is a very common indication for proton radiotherapy. So starting with primary liver cancer, or HCC. As many of you are aware, the majority of patients with primary liver cancer present with locally advanced or unresectable disease due to tumor extension or invasion into major vasculature. And many patients are not suitable for liver transplantation, resection, or ablation, which are known to be more definitive treatments. And oftentimes liver-directed therapies and systemic therapies are what is recommended for first-line therapy. Now, what's interesting about HCC is that, what's underlying the development of HCC is actually liver cirrhosis. And so it's a very delicate balance. You're trying to treat the cancer itself, which is the liver, but you're also trying to minimize toxicity. And anyone who's treated patients with cirrhosis, that they oftentimes can very easily tip into liver decompensation. So it's like sort of a tightrope walk that you're walking with these patients sometimes. This is the BCLC staging system. And you can see that radiation does not yet fall into the BCLC staging, where Laura Dawson and Maria and many of us are trying to advocate for us moving into this. And this is where we've really seen most of the gain for radiation, our potential roles, oftentimes for a bridge for transplant, or for patients that have solitary or larger lesions that are not felt to be appropriate for ablation or surgical resection, or patients just who opt not to undergo any kind of surgery. And when we think about liver-only disease, so non-extrahepatic disease, there are multiple tools in our toolbox that we have to think about when we evaluate these patients to try to optimize what is the best recommendation. Certainly, I think most people recognize that radiofrequency ablation or microwave ablation has the most data to support it compared to surgical resection. Embolization, chemoembolization or bland embolization has a very long track record as well. And then I would say about 10, 15 years ago, liver SBRT has really emerged in the horizon as a very feasible and acceptable treatment plan. And then even more recently than that is radioembolization, so radiation-coated beads to treat the cancer. So when we think about our modalities, we have to think about it in the context of what other options are there. So, I would say for a very long time, there was a lot of hesitancy about treating the liver with radiation, and that's because there was a lot of concern for toxicity. One of the earlier data, because in the 1960s, there really was no way to image the area that we're adequately, that we're treating, that oftentimes the whole liver was recommended. And there was quite high toxicity at low doses, let's say 30 gray palliative doses to the liver. And so there was a lot of hesitancy after that. But, Laura Dawson has spearheaded a lot of work over the trajectory of her whole career, sort of moving this forward. And what we know just from patients that undergo surgery, you can do a hepatectomy and remove 75% of someone's liver, and the remaining 25% will hypertrophy and regenerate, so long as it has that capacity. And so, if we use radiation as ablative strategy, whereas the whole dose, the whole liver may have low radiation tolerance, you can certainly dose escalate to just a select portion of the liver and do ablative radiation that way. And you can see if you do whole liver, the dose tolerance is about 30 gray. But if you are treating just about a third of the liver, you can dose escalate to areas of 90 plus gray. And once again, tolerance may be dependent on whether or not there's underlying cirrhosis or not. Additionally, what's helped the field of liver radiation a lot is multiple technological advances. We're better at delineating targets. We can now fuse MRIs into our 3D CT planning systems. We have MRI-based LINACs, which allow for adaptive radiation therapy. There's improved an understanding of motion management, so 4D planning, active breathing control, abdominal compression, respiratory gating are all techniques we commonly use. In addition, radiation targeting. I routinely put in liver fiducials to help track the liver. Additionally, daily pre-treatment cone beam CTs are performed for all of our photon patients to confirm localization. And then just our treatment planning and delivery systems are much more sophisticated. So I would say in the United States and abroad, far majority of our patients are still treated with photon-based radiation plans. The patient that I treated with 15 fractions, and you can see that we are still able to, this is 5805 dosed here, able to spare many non-involved parts of the liver and have, shape the dose around other critical organs, including the bowel and the heart. There's been bevy of retrospective series, as well as more and more prospective series that have looked at and establishing photon radiation. And you can see the cruxes of what we talk about are local control as well as toxicity. And you can see in well-selected patients, you can have quite high rates of local control on the order of 85+%. Size and extent of disease and dose that you can administer all can impact that. And then when we look at toxicity, you can see that toxicity is relatively reasonable. GI toxicity in terms of duodenal or bowel mucosal structures is critical in terms of thinking about dosing. And then the other, which I would keep referring to, is this idea of liver decompensation, and that's dependent on the underlying liver function as well. And so there's a recent series that showed that if you had a child's QA, which is there's cirrhosis, but it's fairly well compensated, the rates of decline can be quite, reasonable, 11%. But if you have more sicker, livers with child's QB patients, that can be upwards of a third of patients having a 2-point bump in Child's Q score, which suggests worsening liver function. This is a passively scattered proton plan for a patient with a 4-field box for HCC. And you can see it's a 3D plan, and there's ways to further shape and improve that by making it more conformal with adding additional fields. And this is the same plan, but with a 5-field, and it lowers the liver dose. And you can see how nicely the dose fall off is, and sharpened, sparing of uninvolved liver. And this is just a patient that, once again, I treated a 15 fraction and nicely able to spare uninvolved liver. So, I'm going to spend the rest of this time segment on HCC, focusing on the data for protons. There's been early retrospective data from Japan. This was published in 2005 of 162 patients, excellent 5-year local control at 87%, 5-year overall survival of 24%, in part, once again, because of the decrease, because of competing risk of liver decompensation and extrahepatic spread. There's also been increasing prospective data for protons, most of it from Japan. Loma Linda has a very long standing experience with protons and has a prospective study that's been published, and I'll talk about that. MGH, MD Anderson, and UPenn had a combined series, that prospective study phase 2, that was published in JCO. And once again, if you look at the local control rates in these series, it's all excellent, 88% and higher. Once again, overall survival varying dependent on what is the patient population and underlying liver dysfunction that is selected for. So this is our series. I'm just going to spend a few slides talking about it. It's one of the larger prospective series. It was multi-institutional. We looked at Child's Q A and B. We allowed up to 12 centimeters in size. And we opted for 15 fraction treatment, 67.5 in the periphery. Centrally, we dose de-escalated, given concerns for biliary toxicity. And you can see that the median dose was 5805, and that the far majority of patients were able to tolerate and complete the radiation. About half of the patients were treated with primary hepatocellular cancer, about half were intrahepatic cholangio. And our toxicity profile was excellent. 4% of patients with grade 3 radiation-related toxicity. Only one patient had liver failure, but no grade 4 radiation-related toxicities. And once again, this is just highlighting really high rates of local control, both in the HCC and the intrahepatic cholangio population. And all patients with local progression received less than 60 cobalt gray equivalents. The progression-free and overall survival a little bit less, once again reflecting toxicity and out of field failures that impacted outcomes. So I think the reason this paper made it into JCO, as well as Laura Dawson's initial series, is once again, it was just very novel at that time to show that radiation was an ablative therapy. This study also showed the importance of, or the potential role of, radiation as ablative therapy for intrahepatic cholangios, but it more importantly showed that radiation was safe for the liver and that you could really achieve excellent outcomes. So this is a paper that was published in the Red Journal. This is Loma Linda's data that I was referring to. David Bush has a randomized trial looking at protons versus TACE. And these are all transplant eligible patients, and also used a 15 fraction with the primary study endpoint of progression-free survival. So this is an interim analysis, is not completed accrual, but he reported out a trend, 0.06 of improved local control with protons, as well as an improvement in progression-free survival compared to TACE. And also not shown here, there was also improvement in hospitalization rates, which is important in terms of when you think about resources. And then this study came out last year. It's protons versus radiofrequency ablation. And this is where radiofrequency ablation has randomized controlled trials against surgery. So, this is where we're sort of trying to move up and compare ourselves to more and more ablative therapies. This is 144 patients treated and randomized in Korea. There was some crossover based off of whether or not it was felt to be feasible or not, and they opted for 66 cobalt gray equivalent in 10 fractions. It was designed as a non-inferiority trial with a 2-year local progression-free survival as the primary endpoint. And you can actually see protons was felt to be not only non-inferior, but potentially offering an improvement in progression-free survival compared to RFA, both on per protocol as well as intent to treat population. And then when you looked at tolerance, there was actually improved toxicity profile, less patients, lower rates of grade 3+ adverse events with protons, as well as less rates of changes in child's Q score. So I would say this is huge for, radiation in general, but certainly proton radiotherapy. So, the crux of the issue that I keep getting back to is, what is the outcomes really driven by? Is it driven by local control? Is it driven by hepatic toxicity? Or is it maybe driven by both? And so this is when we compare the first study that was really established radiation, which is Laura Dawson and the Princess Margaret experience published in JCO in 2013. And you compare it to our MGH MD Anderson experience, you can see that the local control is great in both. It's hard. it's hard to argue with this. The median gross tumor size was about the same, but certainly there was higher tumor vascular thrombus in the Princess Margaret series. And dosing was perhaps a little bit different. But what was really noticeable was that if you look at worsening of Child-Pugh score at 3 months, that there was about almost a third of patients having liver decompensation versus 3% in our series. And if you look at overall survival, is 34 versus 71%. Now, you should never really cross compare between studies, and I totally, am a believer in that because of all these nuances of tumor vascular thrombus and other confounding factors. But it's just hypothesis generating. And based off of this, we ended up doing, or I should say Nina Sanford, who is one of our trainees who's now on staff at UT Southwestern, also in GI. We reviewed our patients, 133 treated at MGH, 84 treated with photons and 49 treated with protons to see outcomes. And we found no difference in local failure, but there was a significant improvement in overall survival of 31 versus 14 months. And when we looked at why that might be, what really shook out was Child-Pugh increase based on modality and, mean liver dose. So there was improved overall survival, likely secondary to less liver decompensation. And you can see representative by these solid and empty circles that represent patients, that had higher, you can see the photons had much more, the blue had much more bump in Child-Pugh 2+, and that's mostly driven by higher mean liver minus GTV doses. And what is also shook out to be significant was this relative volume of liver receiving less than 10 gray, so like low dose liver to spare low dose liver, and you can see you could more effectively spare with proton radiotherapy. And you could see this on multivariate analysis, adjusting for confounders, that once again, protons was associated with improvement in overall survival, but no difference in local failure. This study was published more recently, and this is a Taiwan series where they, our study didn't do propensity matching. This is still a retrospective series, but they did propensity matching. They likewise found lower rates of RILD, interestingly enough, because of the sparing and the dosing strategies for liver. They were able to dose escalate with a higher BED in patients treated with protons. And then it was associated with improved overall survival, not reached versus 17.4. So I think all of this is supporting this idea that, in HCC, there may actually be an improved survival outcome that we could expect. And so potential explanations for differences, maybe patient selection, maybe fractionation differences, maybe modality differences. All of these are critical in terms of, impact on outcomes. So it's hard to know in these retrospective series. So really the only way to determine it is a randomized trial. And so this is ongoing currently through the NRG system. This is a target accrual of 167 patients, 5 or 15 fractions, and then we're currently at about a third accrual. And the primary endpoint is overall survival with these secondary endpoints. And this is sort of the schema. And this is just, beyond just saying protons for everyone, can we select for which patients may in fact have a clear benefit for protons? And I think that's where we're going next beyond that. This is a study looking retrospectively at our series. We found that patients with no increases in Child-Pugh score had lower pretreatment plasma hepatic growth factor. And so perhaps that's something that we can use as a biomarker to select which patients are probably most likely to benefit for protons. So just moving on now to a discussion of esophageal cancer. As I mentioned as well in the cooperative group setting, there is a randomized trial that's been launched for esophageal cancer as well. And most of the work, I should say, preface this by most of the work for esophageal cancer has been spearheaded by Steve Lin at MD Anderson. You can see that the rates of esophageal cancer overall are declining, but the mortality is quite high still, with an incidence of about 18,000 per year and a death rate of about 16 1,000 per year. So a lot of room for improvement in terms of outcomes. And I would say for GE junctions in particularly, this is increasing incident for GE junction cancers, specifically among white male population for unclear reasons. Radiation is a critical component for esophageal cancer. And we know this based off the CROSS trial that has definitively demonstrated an improvement in overall survival with neoadjuvant chemoradiation. And certainly well established in the definitive setting as well for patients who are not felt to be surgical candidates. And this is data from the recent Art Deco study published in JCO. This was a study looking at dose escalation of high standard dosing versus high dose, where there was no improvement in overall survival appreciated with dose escalation. What I would point you to is that there is, though, increased, not surprising, toxicity with grade 4 and grade 5 toxicity among patients that have that were dose escalated. And once again, highlighting that difficult balance of toxicity and dosing. This is, nice work that Steve Lin has done looking at 3D versus IMRT versus proton beam therapy. And you can see how nicely patients, the plans look when you can spare both for the heart and the lungs with protons. But certainly even photons are with IMRT is nicely able to shape around the heart much more effectively. And for these patients who are going for a definitive resection, which is still standard of care, this really can play an impact and on postoperative complications. This is dosimetric data that has shown that protons can and does yield a decrease in lung metrics pretty much across the board, as well as heart metrics. IMRT 20, a mean heart dose of 20.2 gray versus 7.4 gray for a proton beam. Moving beyond, before I get there, this is just a patient of mine that I actually treated on clinical trial. And you can see, how nicely you can spare some of the anterior structures as well as the lungs. It's not to say that protons is a slam dunk. This patient required a lot of infrastructure for treatment planning to evaluate robustness of movement. But I think that it was still, you can see how nice the plan comes out in the end. Sort of building off sort of the MD Anderson work, Jing Wang was one of the residents there, and she did a large retrospective series looking at postoperative complications, showing that there was notable decrease, significant decrease in pulmonary complications when you compare IMRT to 3D and proton beam versus 3D. No difference when you compare IMRT versus proton beam in this particular study. But you can see that graphically, there's certainly a decrease, and you can understand why based off of the plan. And that mean lung dose really predicted postoperative respiratory complications among these patients. This has been confirmed in multi-institutional series when you pulled 3 or 4 different institutions. Once again, improvement in both pulmonary, cardiac, wound, and length of stay, all translating potentially to resources on the back end for hospital resources, as well as improvement in quality of life for these patients. And then another area of interest that has really been burgeoning is this idea of immune surveillance, where I refer to lymphopenia and how does lymphopenia play in terms of outcomes and survival. And we've always thought about radiation as a local regional in effect. However, we know that radiation can impact the immune system, and this is based off of early work. This is patients getting glioblastoma, and you can see that if you irradiate blood pools over time, the percent of blood pool with doses greater than 0.5 gray, which is felt to be a threshold for lymphopenia, is quite high. And the impact of radiation-induced lymphopenia has now been published pretty extensively in so many different disease sites: cervical cancer, pancreatic cancer, anal cancer, glioblastoma, head and neck. where you can see that grade 4 lymphopenia is associated with worsened overall survival, perhaps due to this like immune surveillance and immune pruning. And this is even more important for esophageal cancer, where recent Checkmate 577 data has now shown that adjuvant nivolumab improves disease-free survival in esophageal cancer and is now FDA approved for patients after chemo rads, after neoadjuvant cross with surgery if there's residual disease. And so optimizing immune cells is critical in terms of the effect of nivolumab. This is more work from MD Anderson that has shown that grade 4 lymphopenia was, in fact, in their series of 544 patients, associated with worse overall survival, disease-free survival, local regional failure free survival, as well as distant met-free survival. So an all outcomes grade 4 lymphopenia was felt to be significant. And when they looked at what was associated with that, they felt that mean body radiation dose was predictive of absolute lymphocyte count nadir, which was at, when you looked at mean body dose of 10 gray or more, it was 16.8 versus 33.7. And when you put that into the models, protons actually fell out of it, suggesting that might be another mechanism in which protons makes an impact in outcomes. So based off of this work, Steve Lin has launched a randomized trial. This is his phase 2 trial of proton beam versus IMRT. It was 145 patients and published in JCO. He did 2 co-primary endpoints. One was progression-free survival, and one was total toxicity burden, which is a composite score of 11 different distinct adverse events. And the study was closed early once NRG GI006 was launched. And he reported out and found that his primary endpoint of mean total toxicity burden was 2.3 times higher for IMRT compared to proton beam therapy, and that the mean postoperative complication score was higher as well. And that the most pronounced differences in postoperative complications were, as expected, cardiac toxicities with AFib or pulmonary toxicities with pleural effusions, ARDS, reintubation rates, and low-grade radiation-related pneumonitis. Of note, there was no difference in quality of life that was seen between these 2 patient populations. And while there was an improvement in grade 4 lymphopenia among patients treated with proton beam radiotherapy, there ultimately was no difference in overall survival and progression-free survival. Now, this was it was closed early, and I think we're all awaiting, hopefully, completion of accrual of this NRG GI006, which is up and running now, that is actively accruing with the primary endpoint of overall survival. So that is the summary of esophageal cancer. And for the last, my last major topic is just going to be anal cancer. Not as much data for anal cancer, and I'm going to talk about that. A lot of the work done here. As many of you know, anal cancer, which are squamous cell cancers, are treated with definitive chemoradiation. It's a huge success story for radiation for organ preservation, with chemoradiation of 5-FU mitomycin as standard of care. And while effective, chemoradiation is one of the tougher treatments that I do, has significant acute and late treatment-related toxicities, especially when they're living with the organs because they're intact. So acute side effects of acute anal rectal dysfunction, so GI toxicity, skin toxicity, heme morbidity with neutropenic sepsis. And those are sort of the acute toxicities, but a combination of both chemo and radiation contribute to that. And then longer late toxicities of anal incontinence or fibrosis, vaginal stenosis, small bowel obstructions, hip fractures, and sexual dysfunction is what we can often see. So, I would say the biggest improvement in acute and late toxicity to date has been Lisa Kachnik's work looking at dose-painted IMRT, establishing IMRT for anal cancer. And when they looked at comparison to 3D, we could see that it significantly improved GI toxicity as well as skin toxicity and grade 2+ hematologic toxicity. And so based off of that, IMRT has now been generally accepted as standard of care for anal cancer and approved by insurance across the board. You can imagine where Protons, once again, does offer some dosimetric advantage compared to IMRD and 3D. Not so much in the high dose range, because like the high dose area that you're treating is right around the tumor, and where it's definitive treatment, you don't want to undercut tumor coverage. But for certainly low dose BAP, I think Protons offers an advantage. So this is work that we did here in collaboration with UPenn, published in the Red Journal. It was a feasibility study of 25 patients that were accrued of pencil beam scanning protons with 5-FU mitomycin. And the primary objective was to establish the feasibility of pencil beam scanning. And this is in part, and it was defined as grade 3+ dermatologic toxicity. And we benchmarked it with 9811. And this is in large part because some of the early data for breast for Protons suggested higher rates of dermatologic toxicity. So we just wanted to make sure, especially given that skin was a huge toxicity, that it could be tolerated. And then you can see our secondary endpoints listed below. And you can see we treated with standard dosing of 5-FU mitomycin, and we did exactly what 0529 did for dose painting. And this is a representative treatment plan of someone treated with Protons on study. And you can see we did a single AP field to cover the groins, and then a single PA field for the mesorectum. And ultimately 23 out of 25 completed proton beam radiotherapy. 2 patients, one at MGH, one at UPenn, ended up dying on treatment. Only one was felt to be due to treatment itself due to sepsis. And then the other one was felt due to acute MI over the course of treatment. And then our median duration of treatment break was 0 days. Median treatment duration was 42 days. This is our treatment toxicity profile, and you could see 56% of patients had grade 3 toxicity, 28% had grade 4, and as I mentioned, 1 patient with grade 5 toxicity. With hematologic, it's always tough. It's driven mostly by mitomycin, but certainly, you know, quite noticeable. And 36% GI toxicity is not nominal. This is the disease outcomes. 88% was a clinical complete response, and our other outcomes are generally quite favorable and in line with what other published literature has shown. When we look at what is our toxicity across the board, and we look at specifically comparing it to 0529 and 9811, you can see for the GI toxicity, it was 36% in our study, 36% in 9811. I think RTOG 0529 had reported 21%, so that did look potentially better. And the overall grade 3+ toxicity was all about in range. It's hard to extrapolate in this from small studies. You know, 3 of our patients did have comorbidities. 2 had inflammatory bowel disease, and 1 had prior TBI, and that could certainly contribute to GI toxicity. But I think where there's a lot of other interesting data for esophageal and HCC, I'm not quite sure that and there's as much meat in anal cancer. So, you know, our conclusion, while it's certainly feasible, it may not offer significant benefit with regards to acute toxicity. And maybe, as I mentioned, this is not surprising because there's many different factors of toxicity for anal cancer, including mitomycin and 5-FU. And longer term follow-up is really necessary to assess for late toxicity. But there are other studies ongoing to further evaluate this. So in the last few minutes, I'm just going to really focus on some of the challenges of proton radiotherapy. One is that there can be range uncertainty, and I'll go into that a little bit more. We talk about how, you know, proton beam, once you have the distal a certain range, there's a immediate dose fall off. So there is some range uncertainty and motion management issues that can occur. Setup variabilities that also can occur, and variability in gas bowel, bladder filling, rectal filling, variabilities in ascites. This is certainly true for the HCC population. Something that I was worried about for treating on study. If patients have pretty significant ascites, I would almost have them either schedule TAPS on, pre-treatment TAPS, or do a weight diary and confirm that their weight is relatively stable. Or if there's significant weight loss over the course of treatment, that can be an issue. And to address this, you could do larger treatment planning margins, compensator smearing, or utilization of several different beams to help adjust for that. Additionally, there is some, ambiguity and some interest and, research ongoing looking at what is truly the RBE at the end of range uncertainty. And so where you range out is critical. Because if there is, we generally use 1.1, but, there's some evidence to suggest that perhaps as RBE changes, there's a change in LET. And so perhaps in the last millimeters of proton range, you can actually bump up to an RBE of 1.3. And so therefore, all of a sudden, you're going from acceptable doses along, and this is a pediatric patient here, going from acceptable range doses on the brainstem to all of a sudden 59 gray, which is unacceptable. And there have been more reports of acute toxicity or subacute toxicity in areas that you're ranging out on, and so something definitely to keep in mind. As I mentioned, there can be some motion management strategies that have to be considered for liver. It's moving with the diaphragm. For the esophagus, there can be peristalsis, and if it's a GE junction, there can be impact of cardiac motion as well. So doing 40 dose calculations, tumor tracking with gating, with external surrogates or fiducials. You need to have motion robust planning, and you can do, there's treatment planning techniques of rescanning to sort of mitigate this. And then additionally, technical challenges of pre-treatment verification. I can say that for photons, all of my liver patients are going to get cone beam CTs. We don't right now have cone beam CT available for our liver patients. And so we've been relying on KV imaging. We have fiducials for these patients, but you can see the confidence in which you have to treat is much less when you're relying on KV imaging versus cone beam therapy. And so, there's so many nuances I can tell you as a fact, on this randomized trial of HCC, sometimes I am randomizing patients, but I am hoping for photons just because of the complexities if the tumor is up against the heart, or if it's, up against bowel. Those are sort of the complexities, and I just have much more confidence with treatment with photons of target verification. And then some additional challenges, as I mentioned, especially in the COVID environment, insurance coverage is getting much tougher and requiring much more, layers of peer-to-peer. This insurance coverage issue can also impact clinical trial enrollment. So how much does our clinical trials reflect our patient population will be another challenge of interpretation or generalizing our outcomes. And then lastly, cost effectiveness of proton beam therapy. As all of you know, protons are an expensive infrastructure. And so really, proving the value of protons, for a healthcare system that is quite crippled at this point. So, in conclusion, this is the state of the union. Just to refresh everything, like for HCC, primary liver, I do think there's strong rationale for protons and randomized trials underway. For esophagus, I think there is really interesting data looking at the intriguing impact on immune systems, and certainly compelling data about toxicity, and randomized trial is currently open. And then for anal cancer, I think it's feasible, but I think the future is less certain. So I'd like to end and say thank you very much for your invitation and for your attention, and I will take any questions.
Hi, thank you very much. And it's amazing you managed to put data on 3 major sites with protons, and a quick summary of where we are and how we reached there. So while we get some questions, I start with the anal cancer because you just ended with that. Would you say perhaps proton might be better in the earlier cancers because there's less volume to irradiate, and you're actually trying to spare the normal tissue more?
Yeah, I mean, I think that certainly, I think there's a lot of things to learn from our experience. I think that, as you mentioned, earlier stage tumors where, there's also this idea of dose, like decreasing dose. I think where you really are, these outcomes are excellent for our patients. And so we really want to, since they're surviving the disease, give them as much quality of life as possible as they're surviving the disease. And I think what we saw is that, how you shape, how you do beam angles may impact things too, like to range out. If I did a single PA, it ranges out on bowel. And I can tell you, I did have one patient that had a colostomy that was strictured. It was hard to know, could that have been RBE and end of range? And maybe that was a higher dose deposition at 54. The plan looked beautiful, but it's hard to know. And, if you, UPenn actually did a few obliques to come off of it. We couldn't do that because of timeframes and, just logistics. But are there ways, even from a treatment planning perspective, where you're thoughtfully figuring out how to range out differently on organs that can impact your outcomes? But I do think that earlier stage is, definitely, something to consider, especially where you are having, if you have bulky nodes or something like that, the carving out of dosing can be much trickier. And I think part of what's been harder to show is just that, I think VMAT or IMRT has done a really good job, and, Lisa had a high benchmark. But I do think hopefully longer term outcomes may show an improve, in terms of quality of life and things like that as well.
So just if anyone's got any questions, either put your hands up or write it in the chat if you're shy. But I just ask another question. So you know, in the last sort of 5 years, the combination of radiation and immune checkpoint inhibitor seems to be the winning combination. And being mindful to the data you're presenting about lymphocyte sparing, do you actually think that perhaps some of the, even though the sort of benefit of the proton sometimes in terms of accuracy or sparing the tumor might be lost, there will be gains if combined with immune treatment?
Absolutely. And, I would say there's a lot of ongoing efforts here at MGH, and we have, we were awarded in collaboration with MD Anderson at PO1, looking at specifically trying to individualize proton radiotherapy, and are there differences in immune responses? I think one of the interesting projects that's been proposed and would be, is, can you look at how, even, let's say vaccine uptake, or, and because there is some data to suggest that proton can ultimately lead to different, perhaps more of DNA strand breaks, and then therefore more, sort of tumor recognition over time, and that will impact IO. So absolutely, the interplay of radiation and IO, and protons in particular, I think will be very, very fascinating moving forward, especially this is just so ripe at this point in time. A lot of the trials, all three, I would say, of the diseases that I presented now have compelling data for IO.
So I just sort of, because I guess me and the other people on this call are proton fans, I think it just helps us perhaps promote a technology which maybe 5 years ago was seen as not being useful because prostate cancer was the favorite tumor site being tested, where the benefits in terms of toxicity and the gains are not so high. but with, as you just very eloquently outlined, the toxicity in these cancers is so severe. The impact of further treatment, if we can not only lessen the toxicity but also enhance that would be wonderful. And yeah, and it's exciting that the funders are interested in the efforts with protons, especially as they are so expensive, especially when you add the immune component too. But yeah,
I mean, it really is like, it's, you know, the yeah, I think we've done a lot of work here looking at, like, you know, immune recognition of the tumor cells with radiation. We, you know, and I think there's just going to be more and more to come. I think a lot of the early data looks very, very promising. So
yeah, thank you. So I can't see who's on the call. Anyone else has got any questions or any queries? So no one. So I think in England it's a school holiday now, and it's Friday afternoon, so everyone is pretty either. Also, somebody's asking any further research in the pipeline, and so sorry, loads of questions have appeared. Have you had any patients with treatment on protons, and how have you compensated unscheduled break if it's an issue?
Yeah, in terms of like if the proton center went down, is that what we're talking about? Yeah. So we always have a photon backup plan. So if necessary, we would treat with photons for a few treatments. I think it comes up every once in a blue moon.
Okay, so I think the machine, the proton beam is pretty stable. So another question is, are there any trials in the pipeline for lung cancer?
There is, you know, I don't specialize in lung. There is a randomized trial, I believe, for lung as well that's ongoing.
Yeah, I think that there was a 15 fraction dose escalation trial in lung going to 60 grain 15 fraction to try and establish a reasonable dose to go forward. But like you, I don't know enough about lung cancer to answer that questions. Okay, so I think somebody's put their hands up. Jamie.
Yeah, hi, thanks, Maria, and thanks for the talk, Jennifer. Firstly, sorry, because I know you did say something about the issues of motion during your talk, but I'm afraid I got slightly distracted just as you were. So I'm just wondering, could you perhaps expand on, so particularly thinking about breathing motion, do you still think that's a technical challenge that needs addressing, or do you think the current techniques are sufficient for dealing with it?
Oh, for motion management? Are we talking about the liver?
Yeah, for the liver, sorry. Oh, well, I guess liver and esophagus and anything that moves.
Yeah, I mean, I can tell you, I have to say, like, for our esophageal plan, it took days of planning. And I don't even understand the complexity. It was like a virtual call with like 4 different people, dosimetrists, physicists, to figure out, like, because the motion that you had to account for left and right, you know, and they had different iterations of what plans would look like at different cycles. We did 4D CT and then they modeled it off of that. And we'd have to determine if, like, the hot spots, like in the worst case scenario of the hot spots, the, you know, worst case scenario of cold spot, based off the motion, would those plans be acceptable or not? I have to say, so there is a lot of planning infrastructure that goes into it, but it's also, like, I think really exciting for them. You know, Steve Lynn's group does it a lot. For the liver, we are, you know, I think we've moved passively scattered. We could gate. We've moved to pencil beam scanning. They're trying to figure out how to effectively gate with pencil beam scanning. I think that has been a challenge. And then, you know, the motion, you know, I would say separately of that, like, you know, I think, you know, there can be motion from organs, and, you know, stomach is, I have to say, I did have a gastric perforation very early. And that was very, you know, that was a learning curve for me. You know, I did a 5 fractions. I wanted to do 15. I wanted to do photons. The patient really advocated for shorter course with protons. You can see with the dips, you can't really see where the stomach is unless you have cone beam CTs, which some proton centers do now. We didn't routinely at the time. You know, what I would say is I tend to, if it's up against a mucosal structure and I'm not confident, or if there's like potential for motion, I back off to 15 fractions, first of all, because there's good data for 15 fractions, and that can be a little bit more forgiving. You know, I think if cone beam or CTs on rails or whatever was available, that would be much less of an issue.
Okay, so you think, so to sort of summarize, it's still certainly a challenge. You've got ways of managing it at the moment, but we could improve on these in the future.
Yeah, and I would say, like, I think, you know, our groups are, that's where like they're actively doing research. And so that's the areas of growth that we have. You know, I think we've done, we can do it. It's, you know, still a learning curve. It's still a lot of infrastructure and like resources for each plan. Not every single, you know, there are patients that we decide are not feasible for treatment ultimately, but I think, I mean, definitely we do it and we've done it, and it's just some of the challenges that can exist. Yeah.
Okay, very interesting to hear. Thanks.
Thank you. So I think I just put one more question, and then we end the seminar. So relates to when you go to the backup photon plans, are your motion management the same for photons and protons? And do you use any sort of compression or breath hold or everything or anything?
So I would say we have not traditionally done that much. I mean, we do 4D CT planning, we do fiducials. I have to say we have found that we do breath hold sometimes for esophageal cancer. Liver, we have not been as much of, you know, we found that for patients who have HC, they oftentimes have underlying cirrhosis for numerous reasons. To regulate breathing can be difficult for that patient population. And sometimes if you can't comfortably regulate it, it actually makes it more erratic. So we've moved away from breath holds, but we evaluated it and then just, you know, but we traditionally do free breathing, but just do with, you know, either gait or not.
Yeah. So thank you very much, and thank you for a wonderful talk. And I also have to, as a host, I have to sort of announce the next seminar, which is on 16th of March, where we've got Dr. Samuel Bakum talking about genomic instability-induced inflammation. So thank you, Jennifer. And I hope to see you soon.
I know.
3D.
Likewise, Maria. So thank you so much for all of you inviting me today.
Bye-bye.